Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to introduce to you now. Dr. Ryan L. Cooley is a cardiologist in Provo, Utah, and has been in practice for more than 20 years. Dr. Cooley is passionate about advocating for lifestyle choices as a means for achieving health through education and as a way to empower patients to make informed decisions regarding their care. His favorite part about medicine is learning something new that helps him help others manage their cardiovascular conditions. He believes that everyone with heart disease can live a long and healthy life. In his spare time, Dr. Cooley enjoys yoga, traveling, and low carbohydrate cooking. He can also be found spending time outdoors, either biking, skiing, playing tennis, or enjoying pickleball. Additionally, Dr. Cooley is active in the community, giving lectures to future medical professionals and spending time as a spokesperson raising awareness for autonomic syndromes. He has also recently started a YouTube channel called Metabochondriacs. Brett Smith and Dr. Ryan Cooley, Awakening and Healing with Metabolic Therapy, with former podcast guest Brett Smith. They will be sharing topics regarding how our metabolic health dictates much of what is happening in our physical and mental health. Dr. Ryan Cooley, what an absolute honor it is to welcome you to Boundless Body Radio.
Thanks, Casey. It's great to be here and appreciate the opportunity.
Yeah, such an honor to host you. I found you the same way I found Brett, which was through Dave Mack's YouTube channel, which is absolutely fabulous. That guy is doing such amazing work and interviewing so many people around the world. I saw your interview there. You did a great job on that interview, by the way. You told me it was your first interview ever, which I think you're a natural. How did it feel to appear on a largely like carnivore type channel as a cardiologist?
Yeah, well, I think maybe 5, 6, 7 years ago I would have said very strange, but now it's definitely I'm very comfortable with that nutritional matrix, if you will, and I'm actually pretty carnivore myself. I still do eat some plants, um, and I can talk about sort of the reasons why I include plants in my diet, but I would say it's pretty darn close to being carnivore.
Funny thing
So
for a
yeah,
cardiologist to say. So
yeah,
interesting.
it's definitely against the convention, the conventional wisdom in the teaching. I think most cardiology practices, especially at least the ones that I've been involved in, heavily focus on Mediterranean-based diets. I think largely because of the touted benefits of olive oil. Um, but I think this is where, there is, I think, some problem and limitation of the evidence base and nutritional and dietary guidelines is that they may scale at a population level, but I think there's definitely potential problems when you're looking at an individual. And so I think what I've learned over the years is that you know we probably would do well to move in the direction of more personalized and nuanced uh, care plans.
Yeah, yeah, that's a really, really good point. Well,
Yeah.
interesting. We mentioned in the introduction that you are just down the road from me. You are in Provo, Utah. I'm in South Jordan, which is just about the halfway point between the University of Utah and BYU. I did ask you right when we got on if you were a BYU fan. You said, well, not exactly. I grew up in Wisconsin, which is great because we bleed red around here, my friend. The only thing we promote at BYU is Dr. Ben Bickman, and that's about it. That's about all we allow for around here. So glad you're not a huge Cougar fan.
Yeah. Red. I'm all about red.
There
So,
we go.
yeah.
There
University
we
of
go.
Utah. Go Utes.
We'll take it. We'll take it, man.
And I love Ben Bickman. He's awesome. He gave a grand rounds for us a few months back. So he was great.
Yeah, I've got to interview him twice on this show. I followed him for a long time, obviously, and finally got to meet him this year at a conference in Las Vegas. And he is just the best. He's just an amazing, amazing guy. He's the very same, whether he's presenting online or in person. His presentations are amazing. He is like the epitome of a wonderful professor. So yeah, we love him around here, and that's about where our love for anything related to BYU ends. But Provo is beautiful. It's where my mom grew up. I'm very familiar with the area. It's a really lovely area, especially for things that you mentioned, like we mentioned in the introduction, like biking and skiing and stuff like that. It's so close to all that. It's great.
Yeah, yeah. So I work in Provo, but actually my wife and I just moved. So we're now actually living up in Heber City.
Oh, gotcha.
Uh,
Very
and it's
beautiful.
abs yeah, it's absolutely gorgeous up here. So I'm really
Nice. Oh, that's
enjoying the move.
fantastic.
I got to
So
drive
let's,
the canyon every day now, so I don't know
uh,
about that.
man, at the time of this recording, I've just seen the photos of the first trees that always change right by Cascade Springs, which is kind of right in between Heber and Provo. So the colors back there are absolutely amazing during the fall.
Yeah, yeah, it's
Um,
gorgeous.
that's awesome. So let's talk about you and your career and your interest in cardiology. How did that all come about?
Um, I think it really started with my family history, to be honest with you. Um, I kind of always had a love for medicine, and I at a very early age, was on a medicine track. Um, but cardiology specifically, I think the interest in that was spirited by my family history, which is rather ominous from a cardiovascular standpoint. My father had a heart attack when he was 35, had bypass the next year, and ended up dying of a sudden death at age 58.
Oh,
And he's the oldest surviving Cooley and in my lineage, dating all the way back to the potato famine in Ireland. So we trace this pretty far back. And so, my father's father died at age 52, I believe, of a massive heart attack. And those kind of that scenario kind of just permeates throughout the history there. And so when we started to look at that, we definitely saw that there were some um, lipid abnormalities that um, I think sort of tracked with that bad family history and that early cardiovascular disease manifestation. And I think we kind of always thought that our problem was genetic. And so at about well, in my undergrad and medical school years, I had a fantastic mentor, Dr. Gerald Doros, who was a very well-known interventional cardiologist in the Milwaukee area and nationally. Nationally, he was very well known. And he was a client of my father, both from a cardiovascular. No, he was a client of my father, and my father was a client of his. So my father was a hairstylist and did his hair, but my father was also a patient of Dr. Doros. But Dr. Doros was very forward thinking, and he really encouraged me to pursue electrophysiology as a career because he thought that's where the future advances were going to be most robust within the specialty of cardiology. And I also kind of just naturally gravitated towards arrhythmias. I like the combination of the cerebral side of it, but also the hands-on procedural side of it was always of interest to me. And so that's kind of what led me down that path. Um, and then at the age of 30, I got real serious about the family history, and from age 30 to age 52 was under the care of a conventional cardiologist, actually several conventional cardiologists. And I had um, pretty robust um, uh, testing along the way. Um, at that time, there was a heavy focus on stress testing as a means for earlier detection of atherosclerosis. So I mean, I probably had 20 stress tests over that 22-year time span and never flunked any of them. I was always very athletic, so for me to get on a treadmill and go 15 minutes was never a big deal. Um, and I always passed them with flying colors. So it wasn't terribly helpful, but I kept doing them. And then I had a lot of um, analysis of the lipidome, my lipid metrics, pretty detailed analyses over the years. And because of the family history, which was marked by a tendency to have low HDL cholesterol, higher triglyceride cholesterol, LP little a, which is which is a an atherogenic particle. It's kind of a small LDL particle, if you will, that is independently associated with the development of coronary disease. Um, and my family tends to all have that elevated, which is, conventionally felt to be genetically mediated. We can talk about some things that refute that. That I definitely think that there's epigenetic influences that can modulate that risk. And then LDL, interestingly, we most of the people that I'm familiar with who've have more detailed analyses of LDL cholesterol, tend to show that we are a type B pattern where we tend to have a lot of small dense LDL, um, and that may have some additional risk implications, uh, composition LDL differences, and when you have a type B pattern, you tend to have this LDL, which perhaps is more atherogenic because it's more easily oxidized, more easily damaged, can enter into the vessel wall more easily. Um, and that was kind of the pattern that was typical in my family. And so because of that pattern and because of the risk, I was advised to take a statin drug, which I did. I still do take a statin medication, pretty low dose, but I do still do that. But I was on a statin for a long time with LDL cholesterol and LDL particle numbers that would predict, um, coronary disease being an orphan disease. We're talking levels in the 20s and 30s for 20 plus years. So my case is kind of a direct refutation of that lipid diet heart hypothesis. And I followed the dietary recommendations of the time. I was somebody who tried to really avoid saturated fat, didn't eat red meat hardly ever, tended to try to eat a lot of omega-3 based foods, fish and so forth, olive oil. I didn't necessarily avoid sugar though. I was definitely somebody who had an addiction problem with sugar and tended to crave sweet, the taste of sweetness. And I think that was a big problem for me. So, over all those years, I kind of slowly, I think like a lot of people, kind of slowly gained weight. Um, and whereas I weighed about 150, 155 pounds in college, I was a college athlete. So I was lean, I think, because I was exercising 2 to 3 hours a day. Um, but slowly gained weight up to about 185 pounds at the time that I had a heart attack at age 52. Um, and that heart attack um, prompted me to switch gears. That's when I started to have luck. Fortunately, I was I've been a lifelong associate with Brett Smith through tennis. And then in the later years, in my 50s, I knew Brett and was familiar with Brett through pickleball and paddleball, but we never really talked about health too much. Um, in those in my early 50s, when I started to play those sports with him, and then when I had the heart attack, that's when we started to kind of investigate and have discussions about, perhaps what I've been doing has been wrong. Um, and I also switched to a lipidologist that um, I think was a bit unique, and luckily found this person and had some more testing, and that's when I really started to understand that my lipid abnormality was, yes, to some degree genetic, but was largely a lifestyle problem. So those problems that I had, those trends that I mentioned were typically in the setting of a dysfunctional metabolic system. I was diagnosed with insulin resistance. And this diagnosis required some deep diving because it wasn't a diagnosis that was made the way traditional conventional medicine makes the diagnosis, which is through fasting glucose and an A1C. So glucose centric metrics. my A1C was 4.9, I believe, at the time, which everybody would say, hey, that's great. You don't have a problem, right? Um, but and this was now, when I had this testing done, I was down about 20 pounds. So I was 165 pounds, and I was 3 to 4 months as a whole food plant-based uh, diet. I had transitioned from what I was doing to now strictly whole food plant-based. So very, very low saturated fat, no animal products at all. Um, and I was diagnosed as being pretty significantly insulin resistant despite that. And my fasting insulin was 16.
Wow.
This is where you sort of get into the problems of the reference range, right? I mean, everybody I think who is understanding of insulin and the insulin metrics knows that the goal of fasting insulin is less than 10 and probably less than 5 as being the most ideal. Whereas I think the reference range goes up to like 20 something, which
I
is
think it's
just
20.
ridiculous.
It's ridiculous.
Yeah, yeah, it's absurd. That just tells you how the problem with the reference ranges and how they're devised to where and it tells you about the prevalence of insulin resistance in the
That's right.
population, right?
That's right.
And I had a full craft test with a 4 hour glucose tolerance test with concurrent insulin measurements, and I had a very abnormal pattern consistent with the insulin resistance diagnosis. And so the that lipidome that I had was in that context. And I think this is where, conventional medicine kind of really misses the boat, is that the prevailing view is that LDL is independently associated with bad cardiovascular outcomes and mortality, independent of context. And I think that's a mistake because I think that there's, all of the prospective randomized trials. I'm not aware of any of them that clearly do not involve a population that is insulin resistant, that has a metabolic lipid defect, either genetic or acquired being insulin resistance, right? Because they don't control for that. The confounder is present in the population because the disease is so prevalent in the population, right? So they'll control for the diabetic confounder, but that diagnosis is based on A1C and fasting glucose. So you're including populations that are very, very likely insulin resistant, but you're saying that they're not because your metric is a problem.
Yeah. Well said.
Um, so it just all started to make sense to me that my root cause driver was metabolic dysfunction, and it was metabolic dysfunction in the setting of exceeding my personal fat threshold. I became overly fat, which led to insulin resistance. And I now know that it was an energy toxicity problem, right? I was just eating too much energy because I really suffered from food addiction, food noise, and food cravings. And it wasn't until I began to understand that and began to listen to people who've been through this experience, and to do some deep dives myself to convince myself that some of the things that we've been taught just aren't necessarily true at an individual level.
Mm.
Um, and yeah, and so um, I began to kind of shift, and she convinced me to trial a ketogenic diet, which freaked me out because I was operating under the dogma that saturated fat will kill you, and I thought at the time that ketogenic diet meant you got to eat lots of fat, right? Um, and so anyway, I did do that, and just by simply reducing carbohydrates from, I think I was probably about 60 to 70% of my diet was carbohydrate at that time, even though it was not refined carbohydrate, it was still a high volume of carbohydrate. I reduced my carbohydrate eliminated grains, eliminated seed oils, and began to liberalize saturated fats. So I didn't fear the fats that came along with the proteins that I was eating. I love dairy, and so I was eating introducing dairy back into the diet, eating more full fat or higher fat um, products, whereas before I would strictly choose low fat or no fat, low fat cheeses, low fat dairy, low fat yogurt. Whereas, when I switched, I basically started eating like Greek yogurt that's 5% fat. Um, and I trimmed up even more just by making that switch, got down to 150 pounds actually. My college fighting weight. Um, and I've maintained that. And I'm about 155 pounds right now, 154, something like that. Um, And I have, really, that my dietary shift to ketogenic has evolved though over the years. I still maintain a state of ketosis most of the time. I have a little breathalyzer that I like to kind of monitor myself with, and I do CGM, continuous CGM, on and off to maintain behavior modification. Um, I think those are great behavior modification tools. Um, and my lipids completely morphed. I mean, I was somebody with an HDL of 20 to 30, which again, was just simply a marker of metabolic dysfunction. And now my most recent HDL is 80.
Wow. Wow.
Yeah, yeah,
It's great.
right. And I don't even think today most cardiologists would say that that's humanly possible, right? We're classically taught that you can't, through lifestyle modification, modify your HDL that much. It's genetic. And yeah, maybe you can exercise and drink red wine and bring it up a little bit, but not 30 to 80. No
Yeah, it's a
way.
huge, yeah,
Right.
huge change.
And the same thing with my LP little a. They say the LP little a is strictly genetic. You should just measure it once in your lifetime to know, do you have the genetic variant or not? My LP little a was 131 milligrams per deciliter when I first measured it. Um, and I don't, I think it's probably the saturated fat issue, because there is science that does say that saturated fat will lower your LP little a, or in other words, low saturated fat, high seed oil diets raise your LP little a. Um, it went to 37.
Wow. Wow. Huge drop.
That's a massive drop in LP little a. My triglycerides run in the 50s, whereas before they were in the 150s. My LDL my LDL cholesterol really never changed much, and because I think that it just compositionally changed, which there was sort of a net neutral effect. I had lots of small dense particles. I don't have that profile anymore. I have more large buoyant, but fewer particles. So my particle count actually went down. My ApoB, since it's been able to be measured, has always been low. Now that's, again, partly driven by statin treatment. But my ApoB tends to run in the 30s and 40s. Again, that would be, conventional cardiology would love that number, right? That's orphan disease numbers, right? You should not get coronary heart disease. And the interesting thing about, I think, my whole situation is that I don't think my LP little a really drove much at all. I just don't think it was a big factor. I think it was having an acquired metabolic lipid abnormality in the form of insulin resistance, which drove higher remnant cholesterol, triglyceride-rich lipoproteins. Um, and when you look at the science, the remnant cholesterol tracks, you know, with much more power cardiovascular mortality and even total mortality than does ApoB. Right. I mean, LDL and ApoB do tend at a population scale do tend to track together. But when they don't, such as in the setting of metabolic dysfunction, it's ApoB that carries more weight. Um, but I have my genetics are interesting. So the other thing I think that my case highlights importantly is just the role of that personalized, uh, nuance, multi-omic perspective, right? I know my lipidome, I know my geneticodome, if that's a word. Um, I have all these ohms that I now understand about myself. And when you are able to take that data and integrate it, I think you get a much clearer picture about what your prescription should be. And so my genetics, I have two gene variants that predict obesity, and it all makes sense, right? Because I just always felt like I was prone to gaining weight. I just gained weight so easily. All I had to do was look at a donut, and I would put on 5 pounds. Um, and I have familial hypercholesterolemia type 3, which is a form of FH that results in a tendency for VLDL cholesterol, which is what your liver puts out. So when you're energy toxic, when you're carbohydrate and fructose toxic, that excess is going to go to the liver, and the liver is going to convert that to fat, package it up in VLDLs, and ship it out. So I have genetically some difficulty managing those VLDLs, right? I don't lip lipolyze those very well, and I have the genetics predict some difficulty with receptor uptake of the VLDLs, which translates into higher remnant cholesterol. And so when you put that genetics of higher remnant cholesterol in the setting of higher remnant cholesterol because of metabolic dysfunction, it's double whammy,
Yeah.
right? It's just that much more injurious and problematic. And when you look at my brother and myself, he's 2 years younger than I am. Um, and so we got similar genetics. We have similar lipid abnormalities, same LP little a problem. And he is whole food plant-based and does really well with that, from the perspective of his lipidome and lipid risk. And he's never had an issue, not as much with his weight. He's always been a little bit thinner than I had been. And he just now had a CCTA, and has no soft or hard plaque. He has no coronary disease, and he's just 2 years younger than I am. Right. So I think that it just all makes sense that the big driver and the difference between he and I is the metabolic health.
Wow. That's incredible. Thank you for sharing that story. I want to go back and ask you what it felt like to be a trained cardiologist. It sounds like, besides sugar, having difficulty with sugar, it sounds like you did pretty much everything that you were told. You were taking the statin, you were eating exactly what they said, and then you ended up with a heart attack. Like, did you just think like you were explaining, like, oh, this is just genetics. It doesn't really matter what I do. This is going to happen anyway. Or like, how did it feel to be in this field and suffer a heart attack?
Well, there are a lot of emotions. I mean, I still struggle a little bit with just feeling guilty. Like I'm not. This wasn't supposed to happen to me, even with the family history. Um, I'm a cardiologist. I should know better. I should be able to use all the data and to be up to date on the science, and be able to implement those things to achieve the best outcome for myself. I exercise regularly, always, my whole life. And so I had that piece nailed down. Um, and then there was anger. At first there was embarrassment. Here I am on the cath lab in my hospital that I'm a practicing, cardiologist, electrophysiologist, and then there was anger. There was anger because as I started to, at first I thought, you're right. I said, this is just a genetic problem. There's nothing I can do. But then other people, in my life, like Brett, said, no, 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 it's not just genetics. You need to be looking into different areas. And so as I started to, really, because I had just taken the advice of my conventional cardiologist. I never did any deep diving into that literature anymore. I didn't really pay attention to the lipid literature. I didn't pay attention to any of that. I just sort of was, pretty narrowly focused on my electrophysiology career. So all the, extra reading that I would do was all electrophysiology based. And that was always then my focus. Um, and so as I started to dive into it, I became angry because I realized that a lot of it is a false narrative, and a lot of it is again, maybe at a population scale, there's some value to it. I'm not going to sit here and kind of refute that, but I think this is the problem with the RCT and the evidence base, which is based on RCTs. And RCTs are largely a tool of the pharmaceutical industry. Um, and I think that it kind of irks me when people poo-poo the N equal one experience, um, because I think that anecdotes do have a lot of power and they do tell us a story. And when you have a lot of N equals one, I don't for a minute think that I am a unique case. I think I'm the common case. Yes, there are a few nuances, but I think again, when you look at my case, it's a case of many years of undiagnosed metabolic dysfunction. And it was present, you know, it was there for the viewing, but it was a tough a thing to recognize because I wasn't obese. I was just overweight. And and there's just so much nuance and individual variability in that you can't look at people and make a judgment. You have to test people, and you have to test people the right way, right? And that's one of the problems is we're not testing people the right way. So there's a lot of education that needs to happen. Um, yeah, so I hope that answered your question.
Yeah, absolutely. And I love the point that you made about N of one. We get in the habit of saying like randomized controlled trials are the very best thing. I've been talking about this a lot lately, where we're like, oh, an N of one is just one single case study. We can't really learn anything from that. But it's like that's the most important thing if you're the case study. If it's your life, then that's the only thing that matters. Every other randomized controlled trial does not matter at all. It matters to you. So I love that you made that point. You mentioned testing the right and wrong way. And so if I made you king for the day and said, okay, what things, how would you change the way that we test? What things are we testing currently that don't really provide a lot of value in your opinion? And what things should we be testing that would provide way more value?
Well, I think that testing for insulin resistance should become a standard preventative, in the preventative package, just like we do the lipid panel, just like we do at a certain age, we test, PSA in males, um, just like we test vitamin D levels. I mean, it should just be part of the primary care package. At what age we should do that? I think, based on the current epidemics we have, it probably needs to be at early ages. Probably people in their 20s and 30s should have a fasting insulin test. And so what I think a very good screen, it's not a perfect screen, but a very good screen is what we call HOMA IR, which is a standardized metric of insulin resistance that is determined by two simple blood tests, fasting insulin, fasting glucose. And you put that in there and you get a single number and it tells you where you are on the spectrum of insulin sensitivity versus insulin resistance. So that I think should be just a universal thing now. Instead of and I'm not saying the A1C or the fasting glucose are paradigms that should be thrown out. I just think we need to shift within that paradigm to something more specific. Because hyperglycemia, which those things tell you about, at a macrovascular level is still a bad thing. So you don't want to be hyperglycemic. But you don't want to be hyperinsulinemic either, right? And that's tells you the diagnosis more than the A1C and glucose do. You can have the very normal A1C and glucose and be insulin resistant. And that's the message for medically trained doctors is you have to know what the insulin is because you'll miss it.
Yep.
And then, there's things within the metabolic syndrome that I think clue you in. Your lipid analysis is something I think is important because it does tell you about your metabolic status. So that just a general lipid panel is sufficient to tell you about your metabolic status. The problem right now is that the focus is on one metric within that lipid panel, which is your LDL-C. The guidelines and the societies are shifting towards measuring ApoB instead of LDL-C, which I think, given the prevalence of metabolic dysfunction and the likelihood that you could have some discordance in LDL-C and ApoB, it's probably a good thing to measure ApoB as well. And then direct imaging for those that are felt to be higher risk for atherosclerosis, but may not have any symptoms of coronary atherosclerosis, direct imaging is the way to go. Either CAC scanning or CCTA, which is coronary CT angiography. And we now have the ability to apply those images, to apply AI-based software to those images. There's a couple companies that do that. And they give you incredible detailed imaging. So you can detect both hard plaque and soft plaque, and you can be very plaque specific in terms of the nature of the plaque. Are there high risk features within those plaques, which can really be something that can be tracked with an intervention, whether it be a lifestyle intervention or a pharmaceutical intervention. There's so much detail that you can easily track them, and you can track them earlier than you would. People feel, the opinion is that coronary atherosclerosis is an extremely slow disease process, and it takes 10, 20, 30 years to have a clinical event. But when you have the detail that you have with these technologies, you can serially, longitudinally assess at a much earlier interval. You don't have to wait 10 years thinking that the disease is so slow going that you won't detect a change until you wait 10 years, right? You don't have to do that anymore. You can wait 1 year because there's so much detail that we know that things can actually progress much faster than we think they can. It's just that clinical events may not happen for 10, 20 years, but disease progression can happen in a much narrower window. And then genetic analysis. I think it's become much more easy to get genetic testing done through simple cheek swabs and with reasonable costs now, either through insurance if insurance covers it, or just even cash pay. The costs have come down substantially, and that can provide a lot of insight. And again, patients, very, very person specific data that can help inform, different risks and help inform a therapy prescription. Right. So my therapy prescription is has really everything to do with satiety and nutrient density. So I really have moved to, so when I look at my ketogenic diet, it's not so much a diet camp that I try to follow. It's more about following concepts of nutrient density and satiety, which I think, and these concepts, what I like about them is that they can be applied to anyone, regardless of cultural sensitivities or beliefs or preferences, because they can apply, they kind of help anyone solve that nutrition puzzle and the confusion surrounding nutrition without getting into dietary dogma. And so I think and the data that is out there surrounding these concepts is growing and getting more and more powerful. And it's about optimal nutrient intake. And the foundation of dietary guidelines are reference dietary intakes, which is the minimum required to not get a nutrient deficiency. It's not necessarily an optimal nutrient intake guideline. And I think what these things are telling us is that there are nutrient bliss points which align with maximal energy intake, right? And insulin resistance is an energy toxicity problem. So it makes sense that we would move away from nutrient bliss points, move away from maximal energy intake towards nutritional intakes that are optimal, that align with eating less energy, right? Whether that be for weight loss or weight maintenance, either one. And that also help with, downstream energy intake, right? So if you are eating in a way that has greater satiety per calorie that you eat, or has greater nutrient density, greater nutrient per calorie, where you are feeding your body the nutrients that it requires to thrive and live long and healthy, you're going to naturally downstream eat less. So for me, that's been my focus. And that's why I still eat plants, because um, it's a prescription that I'm trying to follow and that I utilize, just like we follow prescriptions. I don't understand why I've kind of switched gears in this with this concept a bit. I used to be very anti-calorie counting, anti-macro percentage counting. As like, my mindset was like, who the heck wants to track all these things, right? But I think once you do it for a period of time, you can really hone in on what you should be eating each day. Um, and then you don't have to do it all the time. Like don't I don't put my stuff into a chronometer or a whatever meter anymore. But I did that for a couple weeks. And if I feel like, maybe I'm struggling, I've gone off course a bit, I might just redo it for a week and just make sure that I'm back on track again. Behavior modification, accountability tools are, I think, important. But we do this for everything else. We have our own personal prescriptions for everything, right? We have a sleep prescription, right? People out there, it's like, I try to get at least 8 hours of sleep. When I want to maintain a certain fitness level, I have an exercise prescription for myself, right? I kind of know how many times a day I should be in the gym and how often I should be doing aerobic versus resistance work. Um, People are counting steps, right? You try to get 10,000 steps, right? So that's a prescription, right? So why is it that we just say that following a nutrition prescription is bad or can lead to an eating disorder or something? It just doesn't. Now I've switched gears. I'm like, okay, you got to track this, and you have to do that because you have to have a proactive approach to nutrition that again focuses on your body and mind thriving. And there's very good data. There's data sets out there. Marty Kendall, for example, at Optimizing Nutrition has, over 1 million days of data in free living people, right? Why not follow what works for thousands and thousands of people? And we know that, if you take protein, for example, the protein bliss percentage is about 10%. So people who get 10% protein in their diet that aligns with maximal energy intake. But if you up that to 40, that aligns with the least energy intake. And he's got data on every macro and every important micronutrient as well. So when I look at things like calcium and sodium and potassium and iron. And I try to create a nutritional matrix that keeps me as far away as possible from macro and micronutrient bliss points. I include plants. I include cauliflower and some spinach and things that help me reach those goals.
Yeah. That's, hey,
So
that's great. That's
yeah,
great. You know, ethically, if
and
you're the one,
I'm not saying that being purely carnivore isn't right for somebody. That's not the message. I mean, it's been a great nutritional paradigm for a lot of people for a lot of different reasons. And if that works for people like that and they are healthy and thriving and feeling great, then that's what people should do.
yeah. And ethically, you feel okay killing all the cauliflower? You don't mind if I show up at the picket fence and be like, save the cauliflower? Oh man. Well, right off the bat, to find something that works for you that you enjoy is amazing. I think the foundation of that, like you, should be largely protein. And I love the concept of satiety per calorie because you're focusing on the satiety piece. Like you said, like energy toxicity. If you eat low protein, you are going to be hungry and you're going to continue eating all the other stuff until you get to a sufficient amount of protein. And that might include a ton of calories. The example of that would be sitting down to a bowl of chips and salsa where you never get satiated and you just keep eating chips and salsa and you could have as much as you like. I do lament the fact that Diet Doctor for me was such an amazing, incredible tool that was all about ketogenic lifestyle, and I could send anybody there, and it would have those meal trackers. I understand why they changed. They tried to open things up to be more inclusive to, like you said, like a vegetarian can follow this. You could still be keto, you could be carnivore and follow all of this. So I get it. It just for me it became a harder resource for me to share with other people in their sister website. I believe it's called Hava. But at the end of the day, you're right. Like it's what is working for you, what you enjoy, what you can stick to. All your blood numbers look great. Like having some plants, I don't believe that it's that's like the one thing that you have to do for everybody. So I think it's fantastic that you've been able to incorporate that and see such great results applying that. Is that still kind of the main hub of what you follow, like Hava and Diet Doctor?
Yeah, I still like Diet Doctor. I still go on their website and because I do send people to those websites. I understand the rail against the satiety per calorie concept, and I know people have been vocal, against that. And I think, one of the big problems is that the the science surrounding the creation of the score is a bit, voodoo.
A little arbitrary, yeah.
Yeah, it's arbitrary. But I think it's evolving, and I think it's a work in progress. And I think that those are good people. And I think that at the end of the day, I think it is going to be a valuable model. And that again, I think the more tools you can open up for people, the better. And people just kind of have to trial different things and find out what they like and what works for them.
Yep.
Um, I love optimizing nutrition. Marty Kendall, I think, is phenomenal. I don't, he's got a little bit different focus, but similar, right? So I mean, he does put a value on the satiety per calorie. There's an optimal diet score as well, and how exactly that's derived is a little murky as well. But what I like about Marty's site is that he basically has diet. Like if you think that you're struggling with carbohydrates, for example, or let's just say you're struggling with protein. That's the easy one, right? Because I do think people struggle with how do they get enough protein? What is the goal protein and how do you get enough? Do you look at it from a percentage of your total calorie, or do you look at it as a number of grams per pound of weight or kilogram of weight, whatever metric you're using it to try to target? It's clear that most people are under proteined. Um, and he has a nice little table of proteins, right? It's like, okay, because a lot of people come in, they don't even know what a protein is.
Good point.
and they not sure where to get protein. And then you end up with people, they say, well, I'm quite, most people are quite familiar with protein powders. Right. So then people just start drinking protein powders, and then they start putting things in those protein powders that maybe they shouldn't be putting in. I always think getting protein from natural sources is most ideal. It's not, and I'm not railing against incorporating some protein powder into the matrix if it really helps you achieve the amount that you need. That's ideal. But I always think that, when you eat a protein in its natural environment and within the matrix of it, that's always most optimal, right? And there's data to support that in
Yeah.
terms of effect on microbiome and stuff.
Yep.
But
Yeah. No, I
yeah,
just wish more of us would realize like we're on the same team. We don't need to rail against each other, like you said. Go walk around the mall, go see what really is ailing the country right now. And it's not, whether or not somebody's eating cauliflower, it is because they're drinking gallons and gallons of sugar water and eating seed oils and all this crap. And like if like you said, if you're just
yeah.
moving in the direction of getting more protein in the diet, that's awesome. We're all on the same team as far as that goes.
And I've been helping patients now for, 6 years. And what I see is satiety and cravings. When people are optimizing those are the people that have the most success. And it's not about, just dropping carbs, the carbohydrate insulin model, drop carbs, less insulin, less fat storage. That sort of model is, it's the problem is it's low satiety foods, increases cravings, increases intake, fat accumulation occurs, insulin goes up, insulin resistance develops. And the way to reverse it is high satiety foods, high nutrient density foods, and your cravings melt away. And it's all about cravings.
Yep, totally. Yep.
You can be successful even in our very, very problematic food environment where the opposite type foods are extremely prevalent. You can be successful.
Yep.
Yes, it would be great if our food environment changed, but I don't know if and when that will ever happen, right? So how do we get the most people to be successful? And I think that's what I see anyway, in myself, and then clinically when I'm helping patients try to lose weight. Um, and it's you have to lose fat. You have to lose fat to reverse insulin resistance. You can reduce carbohydrates in your diet, and that will help, especially with insulin boluses. But if you're in hyperinsulinemic still because you're carrying too much fat, it's going to be difficult.
Yeah, that's a good point.
Yeah.
That's a good point. Yeah, and I think you and I are kind of built the same way as far as sugar addiction goes. If I start down that road, I have a really time stopping myself, and I notice that my anxiety comes back, my sleep sucks. Like it just becomes really, really uncomfortable, and it's better to just abstain from that kind of thing. And then you learn what it's like you mentioned, to be in this food world, which yes, we all would love it to change. It's probably not going to change anytime soon because it's a $1 trillion industry. But you can be, like you said, like existing in that world. You can walk by, the kids selling lemonade, or you can walk by the candy bars at the grocery store or the hardware store, whatever, and it doesn't impact you. The cravings do subside, and you understand what it's like to live without those things and how much better it is. It's almost like an ex-smoker who gives up smoking when they can't even hardly imagine what it would be like to go a day without smoking, and over time they understand what that's like. But yeah,
Yeah.
and I also notice a pattern in this community. When you find this information, you get so lit up by it, you just want to share it with everybody. So how has it been starting a YouTube channel and trying to work with Brett to get this message out?
Yeah, it's been fun. I'm enjoying it, and I hope to reach as many people as I can. And this is, one mechanism to increase that scale. It's difficult to while I put a lot of value on the individual patient interaction that I have through my employment with Intermountain, it's limited, right? And I finally got to the point where I felt like I wanted to contribute to all the people who are messaging in this space, right? And I just think the more people that share their stories and the more people that share their experiences, the better. Um, so yeah, I'm super pumped and excited to grow in this space and in this endeavor, and I think it's going to be a lot of fun. So I think going back to one of the earlier questions you had about if I what tests would I recommend that people get, and that first thing I mentioned was that insulin metric. I want to just point out that I was involved in a recent Twitter thread that um, was interesting because it was a thread that involved a cardiologist reporting a great lipid result in a high risk patient with pretty high LDL and LP little a with two lipid lowering medications. Uh, right. So again, it was LDL focused, it was pharmaceutical focused, and I kind of railed a little bit on that, in the thread, and it caught the ire of the cardiologist because I basically said you presented a case with zero context, zero context. There was no information about the context in which this elevated LP, L little a, and LDL existed. And then there was some additional information put forth and to support their claim that LDL is the driver, LDL is the risk, and by lowering it, we're following the data that shows that outcomes are better than your little anecdote that you keep talking about. And that's the mindset again. It's RCT, it's evidence based, its outcomes are way better than the outcomes greater than the anecdote. And the additional information was that this particular person was normal weight. I wouldn't say ideal weight, but normal weight, and that their A1C was normal. And I said, well, you haven't ruled out insulin resistance. Does this patient have an abnormal lipidome because of insulin resistance? And the response was, well, they're not insulin resistant. They're normal weight, they exercise, and their A1C is normal. I said, you haven't ruled it out. And the argument then became, well, what data do you have to support measuring fasting insulin? What outcome data do you have? And my response to anybody who says that we should, who creates a counter argument that we should not be measuring fasting insulin because we have no data, is that in what world would you not want to fix a broken biology? Right? I mean, where does that concept come from? It comes from the fact that conventional medicine is germ thinking, it's isolationist, it's reductionist thinking, it's not internal environment thinking, it's not physiology thinking, it's not our biology thinking. And I just can't understand why people think they need an RCT, why they need an outcomes trial to show that helping people fix broken physiology and biology is not rewarding.
So
It's
backwards.
just right.
So backwards.
So
Wow.
for me, I don't need any more data to know that measuring this metric and telling somebody that they have a functional metabolism versus a dysfunctional metabolism isn't going to have massive health implications down the road. It's just biology, man.
Yep. And thank you so much for adding that. That was so well said and a great way to conclude this conversation. This has been amazing. I love your story, and I love your fire and desire to want to get this message out. Frankly, when anybody tells me that they see this information and one of their first responses is anger, I always get a little bit happy. Like, you should have been pretty angry and still should be a little angry about all of this. But I love that you have found this information. We're open minded enough to consider it, to try it on yourself, and then to learn about it and apply it to other people. So I think people are going to get a lot out of this conversation. And yeah, just really appreciate you. Where can people go to find you and connect with you and your work?
Well, as I said, I do maintain a electrophysiology practice, which has I have incorporated cardiology patients who are interested in risk factor assessment and modification, especially the natural way. Um, my colleague and I are in the midst of forming a cardiometabolic prevention program,
Cool.
which we hope to be completely unique in that space. Again, focusing on true, real valued risk assessments with the things I've mentioned, and coming up with a very personalized prescription, if you will. Um, and we hope to have all the tools for that, which is different than most cardiometabolic programs that, again, are still just focusing on increasing adherence to pharmacological therapy. And then I have two YouTube channels, the Metabochondriacs at Metabochondriacs, which is a joint venture with Brett and I, which will probably be the focus of my online presence. I also have my own, which is at Dr. Ryan Cooley, MD. And there'll be some shared um, info on those, but there may be some, EP specific, electrophysiology specific short videos that I make for that as well.
Awesome. We will link to all of that in the show notes. Dr. Ryan Cooley, thank you so very much for taking the time to be on our show today. That was a great conversation. We appreciate you.
Thanks, Casey. Appreciate you too. Great work.
Absolutely.
All
Thank
right.
you. And this has been
Take care.
another episode of Boundless Body Radio.